Hello guys, good evening. Can I just have your thumbs up if the audio visual is working well? So people who are watching, quickly give me a thumbs up if the audio visual is working well. Okay, a little bit of technical issues I think on my side. Perfect. Now I think everything seems to be settled. Perfect enough. So I think we can quickly get going with a quick overview of the bone infections that I intend to go ahead with today. Because perhaps every exam at least a question comes from the area of this bone infections. So somewhere down the line, a small limited area ensures that at least you get a mark in your pocket. So that's the whole idea of discussing. So I'm Dr. Mukul Mohindra, your orthopedic instructor here at Unacademy. So taking up this small area bone infections, starting first up with this small part, osteomyelitis. Now osteo, as you know, means bone. Mile, as you know, marrow, and itis would generally mean inflammation, and here I am talking of inflammation secondary to infection. So in a simple way, when you have infection in the bone as well as the marrow, that's where you use this word osteomyelitis. Now if at all infection would occur in the bone, by and large it will be the hematogenous mode of spread. The infection would be reaching the bone through the bloodstream, and once this organism reaches the bone through the bloodstream, you will classically find infection first settling up in the metaphyseal area of the bone. Perhaps I think this particular part is very much clear to you. Why metaphyses? Because in the metaphyses you tend to find a very classical pattern of arrangement of the blood vessels, what we call as that hairpin arrangement. Fine. What is hairpin arrangement? I'll just explain that part to you. See, this is an artery that has entered into the bone, what you call as that nutrient artery. Now as this artery would reach the metaphyseal area, it will take a U-turn and return back as a vein. This U-turn type of an arrangement looks like that hairpin that ladies would put up to pin their hair, and this U-turn arrangement is what creates a stasis of blood flow. Now the organism that is already there in the body, not causing an infection on a subclinical way, it's persisting in your body. Now when the same organism reaches here in the metaphyseal area through the bloodstream, its density increases. So that is where it sets up the infection and troubles up the host. So this hairpin arrangement ensures that there is stasis of blood flow, more density of the organism in that area, and metaphyses getting the infection in the bone as well as the marrow. So that's the whole story behind osteomyelitis. Now someone gets osteomyelitis, I don't think I need to tell you the cause. You're pretty much clear with the etiology of osteomyelitis. The commonest cause undoubtedly would tend to be Staph aureus. That will be the overall most common cause. Okay, but what I want you guys to help me out with is this particular MCQ, that what would be the commonest cause of osteomyelitis when you talk of the HIV patients. So can anyone help me out with this particular question? So fair enough that we know that Staph aureus would be the commonest cause behind bone infections most of the times. But what would be the commonest cause in HIV patients? So people watching, please quickly participate. Absolutely no negative marking in my class. A mistake here would simply be a memory. So please feel free to speak, to share your thoughts, to let me know what you think the answer is. So can I have you guys help me out with the answer here? Yes. So the commonest cause of bone infection in people who have HIV. So I suppose you guys are clear with what are the exceptions to this etiology. Okay. So I'll brief you on that. If you talk of the IV drug abusers, this is where the etiology would generally be this organism Pseudomonas. If you talk of people who've got the sickle cell disease, this is where the etiology would generally be Salmonella. if we talk of the people who've had an animal bite, this is where it will be Pasteurella. And if we talk of people who've had a human bite, the causative organism would generally be Eikenella. So these are the exceptions to this etiology, Staph aureus. Otherwise, every other damn place, the organism causing osteomyelitis would be Staph aureus. So please, I have written here IV drug abusers pseudomonas, not immunocompromised, not HIV, not diabetics. So all other scenarios, the cause would continue to be Staph aureus. So even in cases of HIV, the commonest cause of bone infection is going to be Staph aureus. So perfect enough, guys. So I hope this particular small area that's clear to you regarding the etiology of bone infections. Now what sometimes troubles you guys, when the question is changed in this manner, that which is the commonest cause of infection in prosthetic joints. Prosthetic joints, what this basically means, a total hip replacement has been done, or say a total knee replacement has been done. Now a replacement arthroplasty has been done, and you've been asked that what would be the commonest cause of bone infection after this replacement arthroplasty. So guys watching me can't see your responses. I hope the audio visual is working well. You're able to hear me. My voice is coming in a neat and a clear manner. Please let me know if there's any kind of an issue, or just drop in a thumbs up or write down okay if everything is going well. Perfect enough. So I'm finding your responses. Amazing. So the commonest cause in prosthetic joint infections, Staph aureus. You've been trapped. Examiners are sometimes smarter than they look. The answer here is epidermidis. I'll tell you. If you have had an infection and it is the acute scenario, which means less than 4 weeks since the infection, the cause would be Staph aureus. But let me tell you, this is not the overall more common scenario of infection in prosthetic joints. Overall, more commonly it is the Staph epidermidis that is responsible for infections. Generally, it causes delayed infections, but it is also a part of acute infections. So problem with aureus generally causes only acute infections. But epidermidis, this tends to be a part of both acute as well as the delayed infections. So overall more common in prosthetic joints would be Staph epidermidis. Clear? So I hope you are clear with the causes of osteomyelitis overall, in special situations and in cases of prosthetic joints. Okay, so I think now we can just quickly move a little further and take this second one up. That's more or less a question based upon the INICT pattern. INICT, you generally tend to find clinical scenarios, X-rays and clinical history given together, so that you integrate knowledge from your field of radiology, your orthopedics, your clinical experience, integrated pattern. That is the classical pattern you have in INCT, and that you're going to have very soon in the next pattern. So reading this question out to you. So 17 years old male, he's come to you. He's given you 2 weeks history of mild to moderate grade intermittent fever. So since 2 weeks, he's having intermittent fever. He says he used to go for a jog every morning, and his left knee has been hurting him a bit. Okay. And there is no response to analgesic. He's clearly mentioned. Now, he's been examined and it's been seen that the proximal tibia is tender, and on the X-ray, you just need to watch out this proximal tibia. It's been cleared by the examiner, and I suppose you can see a lesion over here. Fine. Now with all these hints, some 2 weeks history, intermittent fever, pain not responding to analgesics, a lesion in the proximal tibial metaphysis, you have to provide me the best answer. Okay, so a vote has come up for Brody's abscess. Any more inputs? Yes, few more inputs. So what could be the appropriate answer here? Quickly guys, quickly. No negative marking in my class. Feel free to answer. Very good. Rahul also says Brody's abscess. Perfect. Any more inputs? Anyone with a different opinion? Add different opinion. D. Chronic osteomyelitis. So let me be clear. It is Brody's abscess, no doubt about it. But yes, whenever you have such kind of questions, a clinical scenario can always overlap. So dear, it's very important that you rule out other options before you come to the right answer. Like, why it is not acute osteomyelitis? Because duration of symptoms would strictly be less than 2 weeks. Generally a few days, 2-3 days. That is how fulminant acute osteomyelitis is. Okay. If it had to be chronic osteomyelitis, clinically you would see a sinus and the duration of symptoms would invariably go beyond 4 weeks. So none of the things is there. And then had this been acute osteomyelitis, what you would have seen on an X-ray at 2 weeks would be a periosteal reaction. 2 weeks history. So acute osteomyelitis will show you a periosteal reaction. I hope you understand what is a periosteal reaction. Pus collects in the metaphysis, pus grows, pus lifts up the periosteum and new bone forms under the periosteum. This periosteal reaction is visible in acute osteomyelitis somewhere around 2 weeks. There is no periosteal reaction visible in the X-ray. And had it been a case of chronic osteomyelitis, I don't think I need to tell you what you would have seen on the X-ray. The hallmark, sequestrum. So you would see a cavity, and inside the cavity this chip of bone, that's called sequestrum. So that sequestrum is not even visible. So with this I can fairly close out the possibility of acute or chronic osteomyelitis. So now I'm stuck with this choice, osteoid osteoma. Now this is a diaphyseal lesion. Okay, and the golden point, what you find here is a diagnostic response in case you have given aspirin, NSAIDs. But see, analgesics, no response. So every other option, there are significant reasons to believe that they are not the answers. And perhaps that's how Brody's abscess becomes the best choice here. With Brody's abscess, the history of symptoms would be generally between 2 to 4 weeks because it tends to be a subacute category of osteomyelitis. And even in Brody's abscess, the commonest site would generally be proximal tibia. The thing is that here the lesion remains contained within the metaphysis because it's an abscess. It does not go outside the periosteum causing the periosteal reaction. So that is how this abscess would generally look like. So perfect enough. I hope things are clear enough till here. You have seen how a sequestrum looks like. I would just like to show you different types of sequestra also because sometimes this is again a popular question that might trouble you in the exams. Sequestra actually of various types. The classical sequestrum is a tubular sequestrum that you see in cases of the pyrogenic osteomyelitis, that is the commonest scenario. But there are some special different type of sequestrums also that can be seen in some very specific situations, especially specific situation like an MCQ. So I'll just brief you a little on that also. A ring sequestrum, this is commonly visible around the amputation stumps or external fixator pins. That external fixator used, the pins you put in the bone, that is where you find a ring sequestrum. So quickly have a look. That is how a ring sequestrum looks like. And quickly have a look. This is how the tubular sequestrum looks like, this tube-like structure. So pretty much clear with the first two types. Now not uncommon it is to find a feathery sequestrum. Okay, and this is something that is seen in something that can never be neglected in India, tuberculosis. So what you see over here, this feather-like chip of bone, this is feathery sequestrum. Fine sandy sequestrum tends to be classical of viral osteomyelitis. A black sequestrum you generally tend to find in actinomycosis. And Bombay sequestrum when bone gets exposure to hydrogen sulfide, H2S. So these are some of the common types of sequestra that you might have to come across during your exam. So please do have a good look, and have a good look at least these pictures. Yeah? Fine. Chronic osteomyelitis. So since we've already touched this topic, chronic osteomyelitis, my responsibility, at least to take you through the treatment part in osteomyelitis. Because bone infections will never be over until we discuss the treatment of osteomyelitis. So guys, this one now for you. You have to treat a case of chronic osteomyelitis, and I've shown you that X-ray also. So I hope you can see there's a cavity containing a dead piece of bone, sequestrum. So please let me know which will not be a part of treatment here in case of chronic osteomyelitis. Yes? So come on, Shubham, Rahul, anyone who wishes to answer, no negative marking in my class. Your students, you have a license to commit mistakes, at least as of now. So can I have some people participating here and briefing me like a little bit about not a part of the treatment in chronic osteomyelitis? Okay, the first option, kyphoplasty of the lesion. Any more options? Okay, another vote. Sharon says no point of doing kyphoplasty here. Any more options? Anyone with a different opinion? Yes, anyone with still a different opinion? Okay, fair enough guys, I'll give it to you. The answer here is no point of doing kyphoplasty. Perfect. See, what is kyphoplasty? Here you inject a compound called bone cement. Okay, and this is injected into a vertebra. Okay, the idea behind this surgery is to treat an osteoporotic compression fracture in the vertebra. So this is a surgery meant for osteoporotic compression fractures, not osteomyelitis. Then you will be thinking that how come this is an option here? Because of this word bone cement, maybe. Because there's some role of bone cement in treatment of chronic osteomyelitis. So I'll just get to you. So you've understood at least one thing, that this will be a part of treatment, this will be a part of treatment, this will be a part of treatment when you're talking chronic osteomyelitis, because the answer here is kyphoplasty, which is not a part of treatment. Now in chronic osteomyelitis, the infection has, got a home in the bone, and that home is a cavity. And then in the cavity, the infection has collected enough food to feed itself, and that food can simply be this dead piece of bone, sequestrum. So if you want to treat chronic osteomyelitis, undoubtedly you have to take help of antibiotics, but you have to make the antibiotics become effective by taking out the cavity, by taking out the sequestrum. So removal of the sequestrum can simply be taken as sequestrectomy. Saucerization is dealing with the cavity. How? By de-roofing it. So de-roofing of the cavity is what you call as saucerization. I'll just clear up myself on this particular area. Guys, see what I'm going to do here. I am going to remove the roof of this cavity. So I'll just do that for you. See, I'm going to remove the sequestrum here. Okay. And I am going to open up this cavity by removing the roof to the external environment. So if you just see here, I have removed this much of bone to open up this cavity to the environment. Now any discharge that will collect over here will flow out because there is no roof. So infection cannot house itself now in a cavity. And then there's a small issue that there's a cavity now, so thin bone is there, so there can be a pathological fracture. So in order to prevent that pathological fracture, fill this cavity with bone cement. So orthopedic surgeons, just the refined version of the carpenters, same equipment, same drill bit, same drill machine, same hammer, screw, everything, same bone cement. But yeah, little more refined one. So this bone cement tends to be a compound called polymethyl methacrylate, PMMA, polymethyl methacrylate. So we fill small defects at times with this bone cement. So you can fill that cavity with bone cement, and perhaps the treatment of chronic osteomyelitis will be over. So chronic osteomyelitis, give at least 6 weeks of IV antibiotics, go with sequestrectomy, remove the dead piece of bone, go with saucerization, open up the cavity so that nothing collects in it, and to prevent a pathological fracture, to make the surgery more effective, fill the cavity with bone cement. So guys, I hope you are thoroughly clear with the treatment of chronic osteomyelitis also. Clear enough? Can I have the thumbs up, or can you just let me know if there's a query? Okay, fine enough, wonderful. So I hope I have cleared to you well enough the treatment of chronic osteomyelitis. Acute osteomyelitis can be handled by and large on medical grounds with antibiotics only. But whenever infection becomes chronic, it becomes established, the treatment is by and large surgical. Even in cases of Brodie's abscess, you have to go with drainage of the abscess. So acute osteomyelitis can be only dealt with medical management. Subacute or chronic osteomyelitis would always need a surgical management. Fine guys. Now another very nice question that's always been a subject of controversy. A 6-year-old boy, he's come to you. Please note the age. It's going to play some important role in your decision making. Okay. Now his complaint is a painful limp. Clinical examination says tenderness in the femoral triangle. You very well know what is femoral triangle, and the most important content of this triangle is the hip joint. So in a simple way, the examiner says there is tenderness in the area of the hip. Now if you can read here clearly, it is written the terminal hip movements are limited. So there is some limitation of the movements of the hip also. Now surprisingly, the X-ray that was clipped is absolutely normal. So now, the problem being clinical, painful limp observable, tenderness in femoral triangle, but with an X-ray that is normal, you get stuck up as to what should be the best choice. So can I just have you guys now answering this one? Yes. So most of the votes as of now for MRI. Anything else? Anything else? Anyone who wishes to now contribute? Sharon, Shubham, SS, Rahul, please, no negative marking. So Petri says D, SS says D. Any more choices? Any more options? Anything else you guys wish to help me out with? Okay, I'll tell you the answer here. But before that, can I have you guys help me out with a simple scenario here? What is the diagnosis? See, you will be able to decide the next step only if you know the diagnosis. So can you just let me know what is the diagnosis? Like, what do you think is the likely possibility in this child? I know Mohit, you are having an inclination to say the answer is D, but please first let me know what is the diagnosis that is in your mind looking at this history. What do you think is the likely possibility? Yes. So what do you think is the likely possibility? See, less than 10 years old kid, and at times he can come to you with a painful limp. Very common scenario. Now when this is the scenario, you have to see what kind of clinical pattern you are dealing with. You have fever that is high grade. You have a severe limitation of range of movements. You have a toxic type of a picture. High grade fever, lethargic child, bad general condition, severe limitation of movements, high grade fever. This is where the possibility that should be kept in your mind should be septic arthritis. Clear? Now the second scenario, where you have fever that is minor type or maybe no fever, and where you have the terminal restriction of the movements, as in this case. What should be your first diagnosis? Something that we say transient synovitis, and this is closely followed by what you were calling as avascular necrosis here, Perthes disease. So transient synovitis would be my first choice here, because it's less than 10 years old child with a painful limb. There is nothing mentioned about the fever, and it's only the terminal restriction of the movements he's having. It's synovitis, not arthritis. Arthritis would mean gross limitation of the movements. Okay. So if it is transient synovitis, see, SS has very nicely written the other name of transient synovitis, observation hip. So full marks to you, dear. So the answer here should be admit for observation, because this is a case of transient synovitis, not a case of septic arthritis. Transient synovitis. Generally some minor injury, maybe minor trauma, or sometimes unknown, no reason identified, idiopathic. You tend to have bit of synovitis in the knee, in the hip. Okay. Now you have had synovitis in the hip. This is going to lead to terminal restriction of the movements. That was the case. The best part about this, self-limiting, generally resolves by itself in a couple of days. So all you need to do is wait for a couple of days. So please have no confusion. This is a case of transient synovitis, and observation should be the answer. Now, where is the role of ultrasound, or where is the role of MRI? I will let you know this part also. So in fact, let me just tell you what to do in this case if the situation worsens. Like, if you think now this case is going to septic arthritis, see, what is the idea of observation? You are observing for the increase of the symptoms. Let us suppose this child now starts getting fever on your admission, or you find the hip movements getting restricted in a more elaborative manner. Okay, that terminal part is not restricted, now more movements are restricted. Like now you are doubting this is septic arthritis. Now the X-ray has been done. No harm in getting even the blood investigations done, because in cases of transient synovitis, the blood investigations like ESR, CRP, they will also be normal. Fine. Now whenever you find it's like infection in a joint coming up, that is where your next step is to get ultrasound, because with ultrasound you can very well detect fluid or pus that is collected in the joint. You find there is pus, you aspirate the pus under ultrasound guidance and get that gram stain, culture sensitivity, and if it is positive, you drain the pus. But yes, when you find no fluid on ultrasound, this is where you keep the space for MRI. MRI is never done before ultrasound when infection is suspected. Okay. So in this case, in this case, you're not talking of septic arthritis. So no point of doing ultrasound MRI as per the protocol in septic arthritis. It is observation hip. So you're admitting for observation that this is observation hip. So in maybe a week or so, since it is self-limiting, the symptoms will disappear. But it is very much possible that more than 3 to 6 weeks have gone, but symptoms are still persisting. So this is the indication of getting MRI done in cases of observation hip, in cases of transient synovitis, because here what you want to check on MRI is the possibility of Perthes disease. Perthes disease symptoms will persist beyond 6 weeks. Transient synovitis symptoms will definitely be gone by 6 weeks. So here after 6 weeks you get the MRI done to confirm there is a vascular necrosis and this painful limp was because of Perthes disease. Because Perthes can also lead to this painful limp with those minor fever or those kind of symptoms. Although classically speaking, limp in Perthes is painless. So are you guys clear with these three scenarios? How sometimes they can have those overlapping pictures. So someone comes to me with this, I know this is transient synovitis, but this transient synovitis could have hidden Perthes hidden in it, or it could actually be early part of septic arthritis. So I have admitted this case for observation. Now I am observing. I find the symptoms worsening. He's going into septic arthritis. This is the order I follow. Or I find it, the case was not worsening. it's chronic case only, low grade symptoms only, but 6 weeks have gone and symptoms have not corrected. So now I start doubting Perthes and get an MRI done. So assess, clear with observation hip, how to follow it up, how to observe an observation hip. And guys, clear what I just told you, that this is observation hip, so observe. And Neha, clear with it that this could be avascular necrosis or what you call as Perthes disease, but if the symptoms would persist beyond 6 weeks, this is a fresh situation, emergency department. So this is not a kind of a chronic scenario. So are you guys convinced and clear with this part? Wonderful, thumbs up. Fine enough guys, fine enough. Yeah, the treatment will be absolutely right now, perfect enough, very good. So treatment will be given as per the symptoms here. So this painful limp will be given some analgesic, putting the child on rest, okay, and you will be just observing him up. As you observe him up, it is possible that the symptoms suddenly flare up. Now you are doubting infection, so now you will be getting an ultrasound done and then going accordingly. But yes, it is possible that the symptoms continue on a low grade mode. You're just observing, but despite a long time the symptoms persist. So minimum after 3 weeks, preferably after 6 weeks, you should be getting the MRI done to check that it is only transient synovitis and not Perthes disease. By 6 weeks, the changes of Perthes will definitely come up on MRI if it will be Perthes. Fine enough. So I hope you guys are clear with it. So that's all guys. You wish to attend more such classes, please go for the plus subscription and go for the iconic subscription, Unacademy the strapped ladder to maximize your benefit. So just taking you through some important events coming up, the free test calendar, just have a look. You can opt for this if you subscribe. The NEET PG cardiovascular system test coming up, some good price discounts if you wish to, and please join to be a part of the list of the toppers. And my special advice to join this all educators revision batch in case you're preparing for this NEET exam, okay, and in case you're preparing for the FMG exam, we also have some options coming for you, everything on the website, okay, and the prices as well. And if you just look at the prices, very economical, very economical. And then just add on this referral code OrthoLife and get you 10% off even on this meager price. Fair enough to get you a pizza at least. Fine. So hope you guys enjoyed the class. We'll take a leave for now. Thank you. We look forward to having you for another special class or a YouTube session soon. Bye bye. Good night.